Well, good afternoon, everyone. Welcome to our fifth session of the day. It's our National Society and Organizational Updates, and we're really thankful for those who have come and are going to provide their input with respect to their organization. We have Drs. Ron Harder, Ira Malka, and Dr. Deppa will be joining us in a recorded presentation later. We'll begin the session with the ASA update, the American Society of Anesthesiologists. They're just getting ready for their annual meeting. I know all my residents are getting their posters and together, and my faculty members preparing to travel, so we're grateful for that. Dr. Harder is the president-elect of the ASA. He has a one-year term that began in October of 2022. He is a professor of anesthesiology at one of my state's institutions, it's Ohio State University. So Buckeyes fan? Okay, all right. So he's definitely a Buckeye fan. He's a practicing physician there at the Medical Center, the Wexner Medical Center, and he's a member of the ASA Executive Committee, Administrative Council, and over the past 3 decades has served at the ASA in numerous roles. And as I mentioned, it's previously the Vice President, now the President-elect. Grateful for you being here, Ron, and look forward to giving us an update on our National Society. So.
All right, thank you. It's a real pleasure to be here, and this is just such a lovely venue, and I've enjoyed having the opportunity to meet some of you and hopefully get a chance to talk to a few other folks here. I've got 20 minutes, so I'm going to, this will really be abbreviated, trying to hit some of the high points that I think are of greatest interest to anesthesiologists. So nothing really to disclose, and there's the learning objectives. So this is our mission, vision, values, and then our strategic plan. And if you just go down the list of our strategic pillars, you can see that there's no way I can cover all the things we're doing in a 20-minute presentation. Even in an hour presentation, I can't cover everything. So hopefully there'll be some time at the end if there's things that I didn't address or didn't address in enough detail that we can have some questions that I'd be happy to answer. So really big thanks to the leadership of your organization. They've put together a great meeting and represent you all very well. So that's certainly a big commitment, and appreciate all of their good work on behalf of AOCA. As you heard, our ASA annual meeting, in case you didn't know, is coming up here in a couple of weeks. I can now say later this month, now that it's officially October. And we track closely the registration numbers. We're tracking ahead as far as total registrants of last year's meeting in New Orleans, which was, so we're not yet at pre-pandemic levels, but we're heading in that direction. And just for, I think there is some, legitimate concern about going to any large city right now, especially San Francisco. There's been some, I think, attention to it of some of the issues that they're facing. But I will say the ASA officers went to San Francisco earlier this summer, and they, the leadership of the city, I think, is well aware that they really need to put their best foot forward to continue to attract conventions like ASA. The city was, especially around the convention center, was clean, clear security presence. So we really are very confident this will be a great meeting experience, and hope to see you all there. So membership, really the lifeblood of our organization. And I, for this meeting here, I wanted to, we don't normally break it down into osteopath compared to allopath members, but I thought for this group it would be kind of nice to just get a snapshot of what percentage of our membership is comprised of osteopaths, and then I asked our membership team for a further breakdown by where people are in their career. So the top, if you can see there, the active members. So those are people who are out of training but not yet retired. So that's really kind of the biggest cohort of our membership, and you can see it's 7.87% of our active members are DOs. And then active EC is early career, and I'll talk about early career member status in a minute, but you can see that, so those are in their first 3 years out of training, so it jumps up pretty significantly. So that, I think, attests to the growing number of DO graduates who are coming into our specialty. So it's becoming an increasingly significant portion of our membership, and then the resident number is even a little bit higher at more than 15%. So it is, I think, increasingly important for ASA to recognize our osteopathic members and to make sure that we're serving, all of our members in the best way that we can. So the early career membership program, as I mentioned, this we have, as we look at our membership numbers, we do a great job, especially lately, the last few years, of getting med student members, because they want to come into the specialty and they see that as something that buffs up their resume a little bit when they're applying for residencies, and may give them an opportunity to learn more about the specialty. Resident members tend to be that most residents are members of ASA, but then there's a significant drop off in their early first few years out of training, and in some cases they never then join at any point, and so that's a huge missed opportunity for ASA, because we're only as strong as our membership, and so we created this early career membership program. We're nearing the end of the first year of that, and there's been good uptake of that. But so for $299, someone in their first 3 years of training gets 3 years of membership dues for ASA, and included in that is either free or deeply discounted educational and professional development resources, and things like, if you want to attend either the annual meeting or our practice management advanced meeting, that there's free registration for one of those meetings over the first 3 years. So any of you who are in training now and going to be entering your practice, in the year or two ahead, please be aware of this. Please join ASA as an early career member. It really is it's an amazing value, and hopefully it makes it obvious what a important part of your career being an ASA member is. So a lot of what ASA pays attention to and devotes a lot of time and resource to is advocacy. There's a number of issues that we're facing, so multiple fronts. Again, I won't go into a lot of detail on this, but I will give kind of a quick overview of the various some of the various things that we're fighting. Medicare payment is a significant issue for us, and it's the Medicare payment for anesthesia services. If you're not aware, it's severely broken. So I don't know if you can see the bars in the back, but there's 3 shades of purple. The dark purple bars show in real dollars what the Medicare conversion factor for anesthesia services has done over the last 20 plus or 30 plus years since 1991, and you can see that's pretty flat. And then when it's adjusted for inflation, that's the medium shade of purple, and you can see it's actually dropped in terms of inflation adjusted dollars, in contrast to the light purple bars, which are that's what we know from our survey of our members of commercial conversion factor rates. So those have largely tracked along with inflation over that period of time. So the differential between what we get from our commercial payers and what we get from CMS for Medicare is that disparity is growing, and that's an increasing issue for our members, because the business model just doesn't work if you have a large percentage of your payer mix being Medicare and in most states Medicaid. So we're doing a lot on that front with respect to Medicare payments, and there's a couple of pieces of legislation in that respect as well. So in order for us to get our arms around all of the various critically important economic issues, we've created a Center for Anesthesia and Perioperative Economics to really assure that we've got the best expertise within within ASA addressing all of the payment issues that we're facing. No Surprises Act. This is an issue that it isn't impacting every group in the country, but the groups it's impacting, it's really potentially devastating for the groups that have been driven out of network by their commercial payers. So there's a lot of things we can do to address that on both the legal, regulatory, and legislative front. Again, there's a lot of depth and detail on this. There have been, to this point, 4 suits against the government by the Texas Medical Association. On the first of those, ASA also filed a suit jointly, which I'll show you, with the emergency physicians and the radiologists. And the Texas Medical Association suit was the first one to actually have its day in court. And so when the court found in their favor, then we withdrew our suit because it was essentially pursuing the same things we were. Since then, we have filed amicus briefs, or friend of the court briefs, again jointly with the emergency physicians and radiologists. And all 4 of those suits against the government have all 4 been found in favor by the court against the government and in favor of the Texas Medical Association. So those all are favorably impacting the implementation of the No Surprises Act, but it's still far from perfect. So continued work ongoing with that. Safe VA Care. This is. And I had an updated slide deck, so this doesn't quite have the things that I had wanted to put in here. But there's increasing awareness of this. The VA has created, or they're proposing, national practice standards that would be applied across all licensed providers across the country within the VA, and including nurse anesthetist. And so the AANA, as well as nursing leadership within the VA, is advocating for independent practice by nurse anesthetists all across the country within every VA hospital in the U.S., regardless of what the state law is within wherever that VA hospital is located. So, so creating a second tier, basically, for the treatment, for the health care of our veterans, the anesthesia care of our veterans, which is just absolutely just despicable. So last week there was a hearing in the health subcommittee of the VA committee of the House of Representatives. I testified on behalf of the ASA on that. There was also testimony from the ophthalmologist, the optometrist, AMA, as well as the AANA. And so there's links going around if you're interested in that. Unfortunately, I had a slide in my updated deck that didn't make it to this presentation, but it's there. This is also making the rounds on social media, where the nurse anesthetists, in their testimony, the AANA, they have an infographic showing that their education and training is equivalent, if not superior, to anesthesiologists. So that's not some fringe militant CRNA out there. That's vetted by the AANA leadership, that they are espousing that they're equivalently trained to us. So these are the kinds of challenges that we're all facing. So within the states, there's a lot of issues, and I won't go into detail because I know there's a lot of states represented here, but every year there's legislation that's brought forward, usually by the state nurse anesthesia association, to seek independent practice or broader practice beyond what they're currently permitted to do. And typically those get defeated, but it requires a lot of effort and attention and resource state by state to do that. There have been some wins with respect to medical title misappropriation, nurse anesthetists presenting themselves as doctors and anesthesiologists, student nurse anesthetists presenting themselves as residents. So there's a good model legislation that has passed in Georgia, and actually passed here in Florida, but it was the governor vetoed it, that clearly lays out here, if you want to call yourself an anesthesiologist or a dermatologist or, a cardiologist, these are the only people who can use that title. And so if this is an issue within your state, please reach out to ASA and we can work with you to help to get some model legislation introduced within your state legislature. AA licensure continues to expand across the country. New Mexico was, their AA's licensure was going to sunset if something hadn't gone through the legislature to make it permanent, so that has gone through. And then Nevada is a state that previously, excuse me, had not had AA licensure that now does. I'm just going to skip ahead here. So ASA guidelines, this is one of the things I think that really is a huge member service and also serves our patients well, that these guidelines are available really for the public. We devote a lot of time and resource to do this, and we have the ability to do that. So this is the two that we passed in this last year's House of Delegates on an update on our fasting guidelines, and then a new guideline for monitoring and antagonism of neuromuscular blockade. So again, those are tremendously valuable to our members and really to the care that we provide. The stars aligned very well for us in that the group that had just been convened to update our fasting guidelines, we were able to reach out to them and our Committee on Practice Parameters because we were getting various very concerning reports from members around the country that patients on Ozempic and other GLP-1 agonists that even though they had fasted appropriately, that they had vomited solid gastric contents, and that it was clear that at least in some patients there was significant delay of their gastric emptying. So it's not far enough along that we've got anything like prospective randomized trials or even big retrospective databases to draw from. So this is largely expert opinion based on what anecdotal reports are, case reports that are being reported. But this is something where we wanted our members to be aware and our patients to be aware, frankly, that this is that this is something for them to be aware of. That if you're a patient on Ozempic or related medication, that your fasting period might need to be increased, as well as the interval that you stop taking the medication before you come to surgery. So interestingly, there's 3 GI specialty societies that said, since we don't have definitive data on this, we're just going to keep advising that we do it the way we always have. ASA has tended to, I think we take a lot of pride in the fact that we tend to err on the side of safety, and so we're still making our members and our patients aware of the potential risks from this, and not just kind of brushing it aside, that until there's good randomized prospective trials, we're not going to have to worry anything about it. So with that, I'm going to conclude, and I'm happy to answer any questions anybody might have. Thank you very much.
Thank you so much, Dr. Hartman. Let's just take a test. Excellent. Okay. Thank you so much for that presentation and giving us an update. I'd like to ask the audience if they have any questions to consider. I have one. Well, if anyone's thinking, we'll be happy to answer their question. But just one question for you. I had a phone call on my way down here from one of my fellows who graduated this year, and he's just started his new job, and he's hired by one of the large capital investment anesthesia firms. And he's like, Dr. Hargrave, they just had our first meeting as a group, and we were told by the leadership the following. We need to plan for medical supervision, running 8 to 10 operating rooms that are independently ran by CRNAs. And we need to do everything in our power to keep our CRNA force basically content, happy working for us. They'll be working independently, and I'm just wondering, when we're talking about scope of practice, we're seeing this legislation come back year after year. Are we now seeing the capital entities lobbying for?
Yeah, so thank you. So great question. There's a lot kind of wrapped up in that. So one, I'll say, happy to talk to you afterwards and connect up with that member and get a little bit more information and get some more information to them as well. So private equity it's becoming a bigger part of really not just anesthesiology, but many specialties. And as with most things, you can't paint it all with the same brush. There are some private equity firms that I would say do practice very much aligned with what ASA recommends as best practice. But there are certainly examples like the ones you're citing that it is absolutely counter to physician, anesthesiologist-led, anesthesiologist-delivered care. And to portray it that, well, in order to make the nurse anesthetist happy, we just have to give them whatever they want. That is that's a path towards disaster. So that's unfortunate. And I would say that we're also aware there are some privately held or owned by hospitals or owned by insurance companies that are advocating for similar models. My opinion has been that because of the shortage of anesthesia providers and anesthesiologists, the workforce issues, I think anesthesiologists have more ability now than they've ever had to say no thanks, to those kinds of opportunities. There are good opportunities available to them that still support care team and independent anesthesiologist, solo practices. So, as these types of practices go on, that makes it, that runs so counter to what ASA really stands for and advocates for. So, but as long as we have members that say, well, I guess that's what I'll have to do, it really makes it an uphill climb for us as a specialty to continue to demonstrate the importance of anesthesiologist-led and anesthesiologist-delivered care. So thank you for that question.
Thank you. Dr. Darwish.
Hi, good afternoon. Thank you so much. This was a very informative session, and actually it's very sad to hear these things that we're facing right now. But I wanted to ask you about AAs working with anesthesia assistants. How, I've heard, I've worked with them before. I worked in the state of Texas, actually, and CRNAs have a very heavy presence there, of course. I've heard that in California, the CRNAs organizations have actually banned the use of AAs, working with AAs. I don't know if that's true. How can we bring that back on the table? Because I think that's a great opportunity for us to perhaps help with this.
Yes, thank you. So ASA very much advocates for licensure of certified AAs. There are about 20 states now where it's either they either have licensure or delegated authority, they call it, which is not licensure. It's sort of a institution by institution can apply for having CAAs, and it's just a matter of getting them approved by their medical staff. That absolutely is an important part of ASA's initiatives. And again, we're doing a lot around workforce, but one of the pieces of that, as far as on the supply side, is to really advocate for certified anesthesiologist assistants. Having worked with both, and as well as conversations with people around the country, and people like yourself that have worked with them, they embrace the care team. They only work under an anesthesiologist supervision. They're not seeking, independent practice. They're not claiming that there are, that they're equivalently trained to us. So, to the extent that we need, non-physician providers, they are a much more collegial advanced practice provider, certainly, than what the than what and that does nothing against nurse anesthetists. There's plenty of nurse anesthetists that work very well within the care team, but specific to the AA&A, their leadership, they really do everything they can to disparage anesthesiologist leadership of care.
Is now, can you hear me?
Yeah, no.
My understanding now is that they're all graduated as doctors. Is that correct?
So they have instituted a doctor of nurse practice, which in something like 85 or 90% of cases has absolutely no clinical training. It's around like simulation education or quality improvement initiatives, things like that. But it's not. They're in no way doing anything that anyone would compare to medical school or residency. But with the DNP, then they are calling themselves doctors, which is why the medical title misappropriation piece is so important. This is just another example where, when you really distill it down, it's an attempt to fool, frankly, patients as to who's taking care of them and what their qualifications is. And if a doctor of nurse practice, nurse anesthetist, walks up to the patient and says, "I'm Dr. Smith, I'm your nurse anesthesiologist," are they going to recognize the difference in training and expertise versus Dr. Smith, the physician anesthesiologist? So if you're in a state where you're having issues with nurse anesthetists presenting themselves as physicians and exploiting this DNP as making it appear to be something that it's not. Again, ASA is working with states to develop legislation on that. Sometimes it can be done through either the nursing board or the medical board. There is, I think it was South Carolina maybe, that their nursing board actually said that their nurse anesthetists could not call themselves nurse anesthesiologists. So there are, sometimes the nursing boards actually understand and recognize that this is something that patients deserve to understand who's taking care of them. But medical boards in Ohio, where I'm from, it's within the medical board rules that you can only call yourself an anesthesiologist if you're a physician. So there's various, as with many of these things, each state has a little different path forward on how to address it. But yes, it's clear that this is part of their strategy. They want to confuse patients and present themselves as something they're not.
Yes, and my understanding is they are calling themselves, "I'm Dr. So-and-so, I'll be doing your anesthesia today."
Yes.
And we've had this problem in my institution.
Yes. Yeah. So again, happy to talk to you offline, and if we can do anything to assist with that, happy to
Thank you.
help
Thank you so much.
We have time for one last question. Dr. Tiwari?
Hello. Hi, thank you for your update. You touched on it briefly regarding the shortage of anesthesiologists. Where I'm from, we're affected in New York. We have operating rooms that are shut because we don't have enough staff to cover them, and it's affecting the bottom line of the hospital, which is important. So as the society, as both of our societies, what are we doing to help that so hospitals like we have back home are not so heavily reliant on nurse anesthetists? This is something we can probably rectify together.
Yes, great question. So we last summer, ASA convened a workforce summit that we brought in stakeholders, C-suite, anesthesiologists from private practice, from academics, small, medium, large group practices, and then we're going to have a second one coming up later this year that will be even a broader audience, including surgeons, AAs, and to assess sort of where we are, what are the further solutions. To grossly oversimplify, it's really a supply issue and a demand issue. On the supply side, we just need to train more anesthesiologists as well as more certified anesthesiologist assistants, get them licensure in more states. And then on the demand side, there has been if you just track purely the growth of nurse anesthetists as well as anesthesiologists as well as CAAs, there's been a nice steady growth really over several years. The problem is the demand is growing faster than even that growth in supply. And so the things where it's really been growing significantly are in things like non-OR anesthesia. Now, clearly with some of the high acuity of patients that are in the non-OR areas, interventional radiology, et cetera, they need an anesthesiologist taking care of them. We're not going to just flip a switch and say we're not going to venture out of the OR anymore. That is an important part of what we do. But that being said, what we're finding, and I hear this from everywhere, is that we've gone from where anesthesiologists were only involved with the more invasive, higher acuity, higher comorbidity cases in the GI suite, for example, to now it's virtually everything that's being done there that they want to have an anesthesia provider. So the ASA1 that's a triathlete getting their screening colonoscopy, they're also getting anesthesia service. So to the extent that we can better identify these are the indications, for having an anesthesiologist there, and then if it's somebody that doesn't require an anesthesiologist, to provide resource to train the gastroenterologist who maybe no longer is getting that as part of their training. That's the other thing that's changed, is now proceduralists coming straight out of training, they've not been taught how to give procedural sedation, so they really, they're very uncomfortable doing that. Well, maybe we can play a role in teaching them to do that. So that's, those are the things that we're looking at. So there's no quick fixes, but I think we've identified some things that we can do that can help to better match the supply and the demand going forward. But you're not unique there, and it's a real challenge. Every C-suite, I think, feels like they're unique and that there's something that they're doing wrong there that's that's causing their problem with OR access. But this story is told again and again all over the country. It's a significant challenge, and it creates other related challenges as far as wellness, burnout, things like that. People are taking more calls, working longer days, longer shifts, more weekends, and work-life balance is very heavily skewed towards work right now for people in pretty much every setting. So we need to right the ship with respect to the alignment between supply and demand for our workforce. So we're working on it, but it's a complex problem for sure.
Well, Dr. Harder, we want to thank you so much for your time here, and I will say that he will be available to talk to anyone after the session. So if you have additional questions, please come up and talk to him about those. But let's join with me, please, giving a round of applause and thanking him for. Thank you so much, Ramon. I would like to ask our next presenter to come to the stage, and I'd like to introduce Dr. Aoca and really just thank him for taking time to come here. I know that you're the OMED National Conference, that's going to be in just a few days, so thank you so much for taking time out of a busy schedule. Just as a brief introduction, he is an AOA board-certified osteopathic family physician. He's a fellow of the American College of Osteopathic Family Physicians, and he practices at the Medical Institute of New Jersey in Cedar Knolls. He's been named a top doc by the New Jersey Monthly Magazine for several years, including in 2013, and Dr. Aoca serves the AOA in many capacities, currently as a president-elect, and including the third vice president, member of the Bureau of State Government Affairs, and the program chair for the 2012 OMED conference. We're very grateful that you could be here today, so please share us a little bit about our home institution.
Thank you very much. I want to thank everyone for being here. I had a wonderful time. My wife and I have been here for 2 days, met a lot of you, and it's a great organization. And listening to your business update earlier, it's paralleled so much to our profession, to the AOA, and we're all in this together. I'm a family doc from New Jersey, and I'm happy to be our president for this coming year. Our OMED meeting is coming up starting Thursday here in Orlando, so we'll be back and forth to Florida for a lot this week. During my president-elect year last year, I started a couple work groups because we looked at some of the key issues that are facing the AOA and our whole profession. And the two biggest issues is membership and board certification. So we started these two work groups, and they're concluding. We're going to get an update on Thursday at our Board of Trustees meeting in Orlando. And our work groups have come up with some suggestions, ideas. The work groups were made up of our students, residents, young physicians in practice, Bureau of Emerging Leaders, and some seasoned physicians to try to figure out ways, what's going on to our profession in terms of why are we seeing tremendous growth within the osteopathic profession, but we're not seeing the tremendous growth that we'd love to see in our membership and those who are board certified. So we're working on that. The same thing with the board certification work group, which is going to conclude shortly with some suggestions. We understand that, number one, we have to get to our students from year 1 and 2. All our students who are in osteopathic schools are members from day one. When you go to a meeting and you ask students, you say, are you a member of the AOA? And you look in the room, they all do the same thing. They look to their left, they look to their right, to their colleagues, friends. Are we members? They're not even sure of that. So we need to work together with ACOM to get to our students, to understand that who we are, what we are, so they better understand what we are, so we could talk about membership, we could talk about board certification, and all the upcoming opportunities as osteopathic physicians they're going to have today, which were not there years ago when many of us started in this career. We also just started a financial work group for budgeting process. We also do have a very strong reserve process within the AOA. And I was trying to do some math real quick in my head because you said 18 months for your organization. I think we are over 2 years in our reserves. But the key is not to use reserves for normal expenditures. Reserves are there for emergency use, for special projects, so that we could use it for the betterment of our profession. Other strategic goals I have this year is to establish a strong working relations with our strategic partners. Again, I mentioned ACOM. ACOM oversees all the medical schools. The deans are involved with ACOM. And NBOME, which is the National Board of Medical Examiners, all osteopathic students have to pass COMLEX 1 and 2 before they're able to graduate medical school from an osteopathic school. They take COMLEX 3 early in their residency. And once you're done with COMLEX 3, you're now able to be licensed in, if not all, but almost all states in this country. And there is no COMLEX 4, but it's really when you go into your board certification state at that point. So these are partners we have besides CDC, NIH, and other federal agencies. We want to have better strategic partners to work together. We have working relationships with Department of Health and Human Services, CDC, other national organizations. We have corporation sponsorships throughout our profession. And we have our biggest strategic partners are organizations like this organization, American Osteopathic College of Anesthesiology, and others listed here. I've attended many meetings, state meetings, national meetings, and we have a great working relationship with our affiliates and our state associations, and we want to continue that because they were also key members of our membership and board certification work groups, so that their input is vital, and the work together with our state association affiliates to promote our main messages is something that we all need to do together. We want to build relationships with our osteopathic physicians for tomorrow, which really starts with SOMA at the school level, and we've had students positioned on bureaus, and they do write reports for the DO editorial board. They are part of the SOMA and part of the AOA affiliate newsletter, which comes out weekly. We have our Leadership Academy, which takes some of the younger physicians and residents and young physicians in practice to get them into leadership positions to be our spokespersons for our profession. And we're working together to have tracks at OMED specifically for the young physicians and residents, and the Parity Township Hall. Now, the parity group is really something that is very vital today. As you know, ACOM has put some legislation through. They'd like to see some parity legislation happen. We at the AOA are looking for a non-legislative solution, which means we want to have equal opportunity for all students in third and fourth year rotations, not being told you're a DO student, you have to pay extra money versus an allopathic student for a rotation in different states. It happens. Also, the same thing with parity in terms of opportunity for osteopathic students who are applying for residency to have the chances to apply for anesthesia on an equal basis with allopathic students. And that just goes across the board for all residencies. So we want parity, and we want to see that happen because we think we deserve it. And we'll talk more about the difference between a little bit of COMLEX, USMLE, and why there's a big push that we don't need to do both. We had 7,850 DOs come into the workforce this past year, 30% increase in our profession in just the last 5 years. We're 11% of the total physician population. And as we graduate today, over 25% of all graduating medical students in this country are osteopathic. That number 11% and the number of DOs graduating and going to workforce are just going to continue to rise until we see ourselves get to that 25% throughout the profession. 57% of our graduates are in primary care, 43% go into a specialty affiliate. This past year, the NRMP match saw a record number of DOs accepted in the first round of the match, over 7,132. When you look at the scramble, we went up to 99.5% of our graduating students matched in residency programs, and in the military, we are becoming a larger percentage of the military versus our general population of DOs applying, and we're seeing a great number of osteopathic physicians in the military, and also an increased number of specialty opportunities arising. Now, with parity is happening at a slow pace, we think it should happen at a much quicker pace because, again, there's some programs that will not allow DOs to apply to, and we think that's discriminatory, and if you don't allow a DO student into a rotation, it's also discriminatory, and we need to make sure we're aware of that. So if anybody has hear of any stories of this nature, please let myself, the AOA staff know so that we can work on it to let these programs know that you cannot anymore discriminate against an osteopathic medical student or resident. We have working partnerships, key stakeholders. We're looking for universal acceptance of COMLEX exam. As I mentioned earlier, we want to make sure that all students have equal opportunity in training programs and residency programs. And we want to also advocate for all DOs and their credentials to have membership on any staff appointments and other organizations throughout the medical profession. We work closely with MBOME, ACOM, as I said, the AMA. We have consensus statements released on terms of our students and our acceptance of COMLEX and USMLE from Association of Anesthesiology Core Program Directors, American Association Directors of Psychiatry Residency, Council of Academic Family Medicine, joint statement by the Physician Medical and Rehab Specialty Societies, American College of Obstetricians and Gynecologists, and others, showing that COMLEX, USMLE are equal, our students are equal, and we have to be treated that way. Here's just a couple pictures of some key osteopathic physicians within our profession who have really made themselves well known in the profession. Dr. Polk is the NASA Chief Health and Medical Officer. We have Hank Chaudhry, who's President and CEO of the U.S. Federation of State Medical Boards, Sister Annie Brooks, CEO of the Tutwiler Clinic, Ronald Blank, DO, 39th U.S. Army Surgeon General and Lieutenant General and Commander of the U.S. Army and Command. We have Omar Latif, who is the President and CEO of the Rush University, who will be one of our keynote speakers coming up at OMED later this week. And Barbara Ross Lee is the first African-American female president, dean of a medical school in this country. So we've got great accomplishments, and we're getting there. We just want to get there a little faster and give equal opportunity for every osteopathic student. We have osteopathic recognition programs in our GME programs, and ACGME is working with us. We'd like to do it a little bit better. We would like to see all residency programs become osteopathic recognized. That would be another great accomplishment for our programs. And if you have a program that you work with and it's not osteopathic recognized, you'd like assistance on getting it osteopathic recognized, please let us know, because we want to make sure that every program has the opportunity to do that. Also, I would love everyone here who works with the residents, I'm sure a lot of you do, if not all, make sure your residency program directors know about our profession, that they accept osteopathic students into the residency programs, and they give them equal opportunity to take our osteopathic boards and not be pushed into the allopathic boards. Osteopathic board certification, we'll try to make it a little bit easier with more remote exams and longitudinal assessments for OCC. There's a new program, if you're a board certified osteopathic physician and you would like to have an OMT designation added to your title, there's an exam and an OMT practical you could take to get this designation. It's not a certification. You have to be board certified first in an osteopathic profession to be eligible to take that. Continuing medical education is a wide variety of opportunities throughout our profession. And obviously, since the pandemic, virtual opportunities have exploded everywhere. Our major meeting last year in Boston at the OMED meeting, we had slightly a greater number of virtual attendance than live. And we're looking forward to see what the numbers will finally be this year. But we had almost 8,000 participants in Boston, and we're looking for a great convention coming up later this week. If you ask, why are you a member of the AOA? I always look at this slide as giving you examples. Why do you want to belong to the AOA? What's the AOA going to do for you? If you look at our state government affairs, it works on scope of practice, licensure, and liability protection, which was more of a problem years ago, and it's less of a problem today, but it's something we still are concerned about. Our regulatory affairs area is Dr. Lona Breen Health Care Provider Protection Act, which is for mental health, burnout issues. Medicare cuts, physician payments, which I'll talk briefly about shortly, and then HIT, which was very critical as COVID hit. We didn't have telehealth medicine approved by Medicare and other insurers, and that quickly changed, and we worked very hard on the legislative area in Washington to make sure that happened, and that was a lifesaver for most of our profession, if not all. And our Congressional Affairs Office works on prior authorization reform in Medicare Advantage, surprise billing, liability issues, and debt relief. And we'll talk more about debt relief in a second, because that is something which is very, very important for our residents today. They borrowed student loan rates of like 2%, 3% years ago, and now they're looking at 8, 9, 10% for payback, and it's impossible to be able to afford the interest charge alone during residency and live a life that you like to, just to be able to pay your bills. And our grassroots areas are access to care, entitlement reform, regulatory reform, scope of practice, and physician workforce issues. Some of the highlights which happened during our DO Day in the Hill and was the $1.44 billion 6-year reauthorization of the Teaching Health Center GME Act, which helps promote clinics in rural areas and supports healthcare in these areas. And a lot of residents participate in the programs through these areas. And it actually used to be a 3-year authorization. And this year, it was up to 6-year authorization. So that was a very good thing to see happen. We got funding for additional 200 Medicare-funded GME slots over 5 years. So it's 200 a year for 5 years, 1,000 slots. When you look at the number of physician shortage, by 2030, we're looking at over 100,000 physician shortages across the board in this country. 1,000 extra GME slots is a start. We need to see a lot more growth in GME. And as mentioned earlier, in anesthesia we need to see more anesthesia. We need every specialty and every primary care area to grow. So we're working on that. So we have a start, but it's not enough at this point. Talking about physician payments, there was a big payment decrease supposed to happen this past year. That 8.5% cut was reduced to just about 2%. Again, 2% is not great. We keep losing grounds a little bit and a little bit. If you look at the cost over the last 10 years to run a practice, it's over 25% increased costs just to maintain and run your practice. And if you look at the increases we've seen from Medicare over the same period of time, it's less than 6%. So Medicare payment funding is not keeping up with inflation and the cost of running our practices, and we have to keep at that. The extension of Medicare telehealth services was a key advantage, but it's only another 2 years authorization. So we're looking for a longer fix to this and possibly even a permanent fix, because certain fields and areas, telehealth services work very, very good. I'm a family doc. Anyone who suspected COVID, we try to do telehealth services first because we don't want to have people exposed and brought into the office, and any other type of infectious disease, flu season is coming up, RSV, as you heard about. We want to be able to treat these patients effectively and efficiently, and telehealth services are a great advantage there. We're looking for appointments for DOs across the board in hospital associations, national and state, federal organizations. We deserve it, and we should get these positions. Our DO Day was this past April. Great day, beautiful weather. You see a picture here of us that were there at the Capitol building behind us. And the 3 key areas that we were all working on in unison was the Resident Education Deferred Interest, the READY Act. Again, it's talking about deferring interest while you're a resident for the 3 years minimum times, because again, if you have a $250,000 student loan balance, and we round it off at 10%, that's $25,000 a year on a salary of mid-60s. I don't know how you pay it. You can't live on that unless you live at home and you have a spouse or someone else supporting you, because it's not going to work. So we're looking to help our residents and have that act initiated. Supporting patient access to care, which is really a way of saying we don't want to see Medicare payment physician cuts anymore. We need to see us grow equal, if not greater than inflation. Like most organizations presented to the government, they get the inflation increases. We're not getting it, and we should be getting it. And I mentioned about the Teaching Health Center GME program. That was a win, and we're hoping to get more wins in Washington. We have a great office and a great staff in Washington, D.C. If you're ever there, stop into the office and see what's going on, because they also run the Osteopathic Advocacy Network. We have a meeting the first Wednesday every month, 4 p.m. Eastern Time, telehealth meeting, talking about federal and state advocacy. We're building influence in Washington. I go to meetings, and our representatives know so many key stakeholders, and it's great support for our profession and for all the affiliates within the AOA. So if you're interested in getting involved, log on to the AOA website, and you'll get information about the Osteopathic Network there. We also have public health initiatives like flu prevention, social determinants of health, others through osteopathic.org, and you could see a lot of key areas that we're working on. We partnership with various stakeholders. Again, you see a lot of what we're doing here in terms of issues that face us every day as practicing physicians, and we're very, very much involved with all areas of medicine, and all our affiliates are together working with us on these issues. We have our DO Proud hashtag. Again, if you go to osteopathic.org, you can learn more about the DO Proud issues that we're involved with. We wanted to make people understand the distinctiveness of osteopathic profession and how we differ and what we do for our patients and how we treat them and how proud we are to be osteopathic physicians. Diversity, equity, inclusion is a major part of our workforce environment. We make sure our staff, our committees, councils, bureaus are equally represented as best we can, and we're making sure that we have programming at OMED in this area, and we want to make sure that we meet all the standards within our obligations to healthcare. Physician wellness resources, burnout is a big issue, and it's talked about due to the stressors of our work schedules, our payment schedules, our home life, our social life. So there is demand, wellness webinars, discount on wellness apps, again through osteopathic.org, physician wellness. I always mention that it's key for me to talk about 3 areas on burnout. If you're not taking care of yourself as best you can physically, dietary, try to work on it as best you can and make a difference. You'll feel so much better. Keep in mind your BMI numbers. Try and get them down as close as you can to 25. Get to the goal of 20 to 25 if you can, and you will feel better, and it will help you emotionally and physically. And number 2, emotional support. Look for it from your colleagues, from your friends, from your partner, spouses, your family. They're all there for you, and we're all in this together. We all want to work on it together. And the last area is your spirituality, and whichever way you find that way of, helping yourself, make sure you continue that in your daily affairs. Now, we have AOA Assist physicians who have issues and problems, you can see here, in different areas of your practice, of your life, HR, opening practices, closing practices. We have meetings with all insurers and ways to help our profession. So we're there for you. We are continuously trying to improve on what we do. Again, if there's areas or concerns that anybody has that we can help you, please let us know. Our staff is there for you. You could download the AOA mobile app. It's a nice little app here. It gives you news feed, CME tracker, talk to you about discussions and community affairs that are going on within our profession. OMED 23, right around the corner, starting Thursday this week in Orlando. If you can make it, we'd love to see you, and it's still open. Please join us if you can. If you plan on staying, come over to Orlando. It would be a great time. Thank you very much. That's my update from the AOA, and I'd be glad to answer any questions. And I appreciate the time here to be able to give you this update, and I thank you for a wonderful conference to be here. Thank you.
Are there any questions from the audience for our AOA president? Well, I don't see it at the moment, but certainly you'll be around for a few moments if there are any questions that would come up. And if not, stop by and say hello and introduce yourself to the leadership that represents the osteopathic medical profession. So thank you so much for being with us. It's been a pleasure to have you here. Finally, we're going to watch a brief update regarding the Osteopathic Anesthesiology Board Certification Organization. So I believe Dr. Deppa pre-recorded. And for those of you who do not know Dr. Deppa, he has been a leader for some years in the board certification process for osteopathic anesthesiologists. He was recently the president of the Board of Osteopathic Specialists. He is now the president of the OCC, the Osteopathic Continuing Certification Process for Anesthesiologists. So we welcome Dr. Deppa and look forward to his update.
Good afternoon, everyone. I am Ray Deppa. For those of you who don't know me, I'm a private practice anesthesiologist in Central Kentucky. I am the immediate past chair of the Bureau of Osteopathic Specialists, fellow of the American Osteopathic College of Anesthesiologists, and a proud diplomat of the American Osteopathic Board of Anesthesiology. I am on the ALBA's Longitudinal Assessment Item Writing Committee. My sincere apologies that I cannot be there in person with you today. Unfortunately, like many of you, my practice has ran into some persistent staffing issues and I'm unable to get away from work. Both the AOCA and the AOBA have meant so much to me and my family, and I'm truly grateful and proud to be a member of this specialty college and our specialty board. It is a real privilege for me to be able to bring to you today the AOBA's update to OCC Component 3, Longitudinal Assessment. Just a brief reminder, there are 4 components to OCC, and this process is a continual process designed to ensure that our diplomats remain up to date in the many advances and improvements to patient care during their career. Component 1 is maintaining an active state license. Component 2 is lifelong learning or continuing medical education. Participation in wonderful conferences like this will ensure that you complete this requirement. Component 3 is a cognitive assessment, which has now been transitioned away from a high-stakes recertification exam to a longitudinal assessment using MBOME's Catalyst system. I will discuss that momentarily. Component 4 is the practice performance assessment and improvement, which can be accessed via going to the AOBA website and completing an online attestation. All AOA specialty boards have launched or are in the process of developing longitudinal assessment programs designed to replace the high-stakes recertification exams that were taken between 6 and 10 years after a diplomat's initial certification. The benefits of longitudinal assessment include: 1, maximizes the convenience of a remote proctored exam while minimizing your time and expense spent in preparation and travel for a high-stakes examination. 2, the assessment can be completed when and where is best for you. This offers you increased flexibility and less stress that is often associated with high-stakes, one-day examinations. 3, it provides you with immediate feedback after each response that includes a reference to the source for a question. And 4, it validates that learning is a continuous process and allows you to immediately apply information to your practice in an ongoing basis. With the support and commitment of the AOA to improve recertification process for its diplomats, the American Osteopathic Board of OBGYN, American Osteopathic Board of Internal Medicine, and our board, the American Osteopathic Board of Anesthesiology, were the first specialty boards to adopt the longitudinal assessment program in 2019. However, our first longitudinal assessment platform in 2019 was only intended to be a bridge to get us to where we are today with the NBOME's Catalyst platform. In a few moments, I will explain the NBOME's Catalyst platform and give you some examples of how it works and why we're excited by what this platform has to offer and the innovation it demonstrates in assessment. But first, I will speak more to the AOBA's longitudinal assessment plan, which launched in January of this year. Specifically for the AOBA, the purpose of this longitudinal assessment plan is to provide high-quality evaluation of its diplomats while allowing greater flexibility to meet the OCC Component 3 requirement. It is designed to give diplomats the freedom to access content that is relevant to their specialty, all the while keeping with the true spirit of continuous lifelong learning that longitudinal assessment has to offer. Longitudinal assessment is an annual process, meaning that after you have entered the process, you'll have to register and complete assessments on an annual basis. Regarding the 2023 assessment segment, which is currently running, there are 2 groups of diplomats for whom completion of the 2023 assessment is required. Registration is now closed. If you have any concerns or issues with this, please reach out and contact the AOBA office if you need assistance. The 2 groups of diplomats who should be participating in longitudinal assessment for 2023 are the following. 1, diplomats who have previously participated in the AOBA cognitive assessment in 2019 through 2022. And 2, diplomats with time-limited certificates expiring in 2023. The 2023 assessment segment questions will be available for completion on the Catalyst system through December 15th of 2023. Regarding the 2024 assessment segment, registration opened in June 1st and will close on October 31st of this year. The first late fee will be applied to applications who register after September 16th of 2023. After registering, this segment will be available starting in January of 2024. And email reminders will be sent out to register for the assessment. Registration for this segment is required for the following. 1, diplomats with 10-year certifications expiring in 2024. I am part of this group. 2, diplomats noted previously who would have registered for and completed the June 2022 assessment segment. 3, diplomats currently completing the 2023 assessment segment. And 4, diplomats who received their initial certification in 2021 and 2022. Note that each assessment segment coincides with the OCC cycle, which lasts for 3 years. As previously mentioned, the Catalyst platform is an assessment tool used to drive learning, provide performance feedback, as well as educational resources for what is being assessed. The platform is highly customizable depending on how the specialty boards have constructed their longitudinal assessment. Specifically for the AOBA, diplomats will be required to answer 30 untimed questions, multiple choice questions, related to topics from the OCC table of specifications. Diplomats will have a total of 2 attempts to get the answer correct. And diplomats must achieve a score of 70% or greater for each assessment segment. It is our belief that this transition to longitudinal assessment better enables our diplomats to continually assess and improve their skills, and again, offers an assessment that truly enables our diplomats' commitment to lifelong learning. Here's an example of a couple of sample questions from the Catalyst system. The diplomat will receive these questions on their computer, tablet, or mobile device. Excuse me. The responses are untimed. For each incorrect answered multiple choice question, a reference and/or correct answer will be provided. Each incorrectly answered multiple choice question may be reattempted during the reattempt phase. This shows a screenshot from the Catalyst platform dashboard. On the far left, it shows a comparative performance of you compared to your colleagues. In the middle, shows the individual performance, how many questions you've answered correctly and incorrectly, and how many remaining questions there are. And to the far right is the progress. You must, which shows how many days remaining you have to answer the assessment questions. To recap, in 2023 and moving forward, the AOBA longitudinal assessment will be offered on the NBOME Catalyst platform. Each year's assessment will require completion of 30 multiple choice questions per year, with the first attempt between January and September, and a second attempt if needed between October and December 15th. A score of 70% or greater is required for each year's assessment. In addition, registration for the following year's assessment will be available between June 1st and October 31st on the AOBA website. This slide shows the many upcoming examinations that the AOBA has scheduled for 2023 and 2024. The exam dates are similar to previous years as indicated. The primary certification exam was administered on August 2nd. The upcoming 2023 oral exam will be administered on October 14th. All of the AOBA exams are now administered using a secure proctored remote platform. I want to take a moment to note that the focus of our work has primarily been with launching the longitudinal assessment for our primary boards. Now that we have made such significant progress in developing and executing on our timeline with NBOME, we will begin to turn our attention to developing a plan for transitioning our 49 subspecialty exams to longitudinal assessment. This will include the AOBA's subspecialty exams. Operationalizing all of these subspecialty exams will quadruple the effort that has been done to date. However, we look forward to reporting on these efforts to you in the future. As noted, the annual longitudinal assessment fee is $210, and after the first application deadline, a late fee of $65 will be applied. As always, the AOBA invites any of you who are interested in becoming one of our content experts for item writing or participating as an oral examiner to reach out to us to participate in our distinct osteopathic board certification process for our current and future diplomats. Item writers do receive CME credit for their time, and they may also qualify for additional benefits if you reach significant contributor status. Finally, I just want to take a moment to thank the entire AOBA board, the other members of our OCC Longitudinal Assessment Committee, Dr. Helen Bean, Dr. Tanya Schnell, Dr. Pooja Trivedi, Dr. David Paul, and Dr. Brent Groff. I would also like to thank members from the NBOME team, including Emily Mortarola, Gina Falsetto, and Kathy Green. From the AOA Director of Project Management, I'd like to thank Mr. John Yelton and Ms. Jean D'Angelo, Senior Director of Assessment. And I especially want to reach out and thank the Certification Director for the AOBA, Ms. Katrina Matthews, and the Certification Specialist, Ms. Kate Jackson. If you see these folks at the conference, please take a moment to thank them for their tireless efforts, professionalism, and commitment to helping develop a successfully operationalized, enhanced longitudinal assessment program for all of us. It has been a major undertaking to develop these exams and transition them to a remote proctored platform and to successfully operationalize the exam experience for our diplomats. Thank you again for the privilege of being able to speak with you this afternoon. If you have any questions regarding the certification process, please feel free to direct them to the AOBA's team at aoba@osteopathic.org or via phone at 312-202-8279. Thank you again for your attention, and I hope you have a wonderful time in Florida, and we'll see you next time.
Well, thank you, Dr. Deppa, for that very insightful update. And I will say, and I'm very glad to say, that we have representation from the AOBA here today. There's a table right out in the hallway, and they are present and able to answer any questions that you might have. I know there's a lot to take in with respect to the longitudinal assessment. It's a little bit different, but it is something that helps to move our process forward. So we're very grateful for their presence. So thank you for being here. We are now going to conclude the session. I will just remind everyone, please complete the feedback and claim your CME for this session. It all happens directly in the mobile app. We'll have a brief coffee break, and then we will return for our keynote address with Dr. Derek Ledeco at 2 p.m., and he was going to be speaking on anesthesiology and austere conditions. So you don't want to miss that. So enjoy your break, and thank you very much to our speakers for this session.